In this video, we present the case of a patient with adenocarcinoma of the pancreas and liver metastases located in the right liver. In the 3D reconstruction, the simulations of both tumors can be seen in pink. In this picture, the relative position of the patient, the surgeons and the surgical robot is represented. An extraglycerinian approach to the right hilar pedicles is performed, following the concepts of Takasaki and Sugioka. The surgery begins with a cholecystectomy to identify the posterior section plane of the parenchyma and the identification of the anterior and posterior right hilar pedicles. As in laparoscopic surgery, in robotic surgery the Pringle maneuver is mandatory and must be prepared to prevent and manage bleeding problems during the course of surgery. The use of the Wong loop is very useful and very easy to do with robotic devices. To do this, we use a urinary catheter. Next, the right anterior pedicle is identified. To do this, the Laennec capsule is separated with blunt maneuvers at gates 4 and 5, eventually surrounding the pedicle with a tape. The pedicle is completely surrounded and can later be clamped to mark its exact extension. Subsequently, the right posterior hilar pedicle with its corresponding gates is identified and it is also surrounded with a tape and subsequent clapping. The demarcation of the ischemic line is visualized. The surgical robot allows to have a coupled image of the intraoperative ultrasound in the same visual field. The middle hepatic vein and the subsidiary veins of hepatic segments 5 and 8 are identified. Next, partition of the liver parenchyma begins. For this, robotic instruments are used that combine the parenchymoclasia and high-energy sealing. The use of the Maryland bipolar forceps allows a perfect dissection of the vascular and biliary structures. As the parenchyma partition progresses, the use of polymer clips may be necessary. Identify the vein of segment 5 that is clipped and sectioned. Next, the veins of segment 8 are identified and sectioned, with which special care must be taken due to the risk of opening. For the section of the right anterior and posterior hilar pedicles, we used the robotic endostapler with triple staple line, adjusting the staple size to the thickness of the tissue we want to section. We generally use 3.5 mm staples for the pedicles. It is important to do these maneuvers with a short Pringle. The dissection follows the anterior wall of the vena cava until it reaches the entrance of the right hepatic vein. This vein is surrounded with a tape and later sectioned with a robotic endostapler with staples of 2.5 mm in size. The right liver is then freed from its adhesions to the diaphragm and the small veins draining directly to the vena cava are divided. For distal pancreatectomy, the inferior part of the pancreas is freed from its adhesions and the splenic vein and artery are identified. Splenic vessels are divided using polymer clips and robotic endostapler. The pancreatic parenchyma at the junction of the body and tail is incised with an endostapler. Both surgical specimens are placed in plastic bags and then removed.